Mr. Roskam is recognized.
Thank you, Mr. Chairman, for your leadership in convening this hearing, and for Mr. Blumenauer and his thoughtful setting of this, the discussion. I think most Americans, when they hear these numbers, are actually scandalized by them. It's very difficult to absorb. We're in this very sort of clinical antiseptic setting, but this is a situation that's bad, it's been bad, and it's actually getting worse. This is not getting better. And these are the numbers, these are objective numbers. So CMS's own numbers in 2010 said that this number in terms of fraud and abuse and waste and so forth was $48 billion. A year later, it jumped up, according to GAO, to $64 billion. The latest estimate from the FBI is $75 billion plus and climbing. So, Doctor, with due respect, in my view, you don't get to use words like top priority, robust, and strongly positive. They should be out of your lexicon. This is a scandal. This is an embarrassment. And there's an irony in that Ms. Jarman, in her opening statement, makes an inquiry of this committee, would you please support our request for a budget and appropriation? And the irony is, you've got all the money already. So can you imagine the level of confidence that would be buoyant in our country if we were able to come together? And you've brought us together in ways that we've never been brought together before. As Mr. Blumenauer alluded, we can hardly agree what time it is between the two of our parties. We cannot agree on what day of the week it is. And yet we are nearly unanimously scandalized by just these big, big numbers. And so I just have I've got three inquiries of you, and I recognize you're the new person on the job. You've been there 2 months. So I'm measured by that. But so here's three legitimate issues that are upon us that have broken through. One is the Medi-Medi data sharing. This is this whole notion of Medicaid and Medicare being in communication. If there's fraud in one area, communicating that in another area. Right now, only 10 states are participating. In my view, that's ridiculous. What's your remedy to that?
Thank you. I think the Medi-Medi program is very important for our activities. It does, as you pointed out, allow us to exchange data with the states so that we can, again, find those providers and schemes that are crossing the line between Medicare and Medicaid and kind of committing schemes against us all. Expansion is an important element of that, and we have been working to expand the number of states that participate in Medi-Medi. This is, I would just point out, a voluntary program, and there are a number of other data exchange activities that the states are engaged in. We've heard consistently from them that while they would, in some cases, value participation, they have to weigh that against other priorities and data exchanges that they have. So we are very open to more expansion, have actually added more states since that figure of 10, and I could get you a more updated number.
So the next time we meet in a hearing setting so that you can claim those superlatives that I admonished you from using before, what's your plan in terms of the Medi-Medi goal? Let's say you're back in a hearing in 6 months. There's currently 10 states that are participating. What is reasonable for us to assume? Reasonable. I'm not asking pipe dreams. What is a reasonable number for you to coax, cajole, urge states to participate if only 20% of the nation is participating now?
I'm not sure that I could give you a specific number.
Sure you can.
That would, to kind of, for a follow-up hearing. I think what is important to note is that Medi-Medi is just one of the many activities that we perform with the states. We also collaborate with them in the Medicaid Integrity Institute, which is all about best practice and knowledge sharing. We work with them on specific cases that might fall out of the Medi-Medi context, but are active investigations either that we've initiated or that they have. So I'm not sure that participation alone in Medi-Medi is the best measure of how well we're
but it'd
collaborating
help.
with the
I mean,
states.
my home state of Illinois just paid out $12 million to people who were dead.
Yes, sir. I also am aware of that. I think I go back to the answer that I had about Medi-Medi. If you're asking specifically about Illinois, I could certainly look into what activities we have with them.
So here's my question. If only 10 states are participating, and we're losing $75 billion a year, according to the FBI, doesn't it follow that if we had every state participating, that this gets better? And don't you play a key role in whether every state participates or not? Am I over-characterizing this?
I think it's fair to say we, too, want more states to participate. I think.
What's your plan to have that happen? That's my question.
So we have lots of outreach activities with the states to let them know about the existence of the program, to indicate the sort of portion of the Medi budget that we are willing and able to handle versus what they would need to undertake. And we engage with states in numerous different venues in order to be able to do that. Again, I believe states are under a lot of pressure to also produce data for CMS, including the TMSIS program. So there will be exchange of data, and I'm not sure, again, that Medi is the singular kind of measure of that collaboration.
But you're not satisfied with 10 states, are you?
Oh, we always want more states to collaborate.
How many more? Next time we meet, how many more is a reasonable number?
Sir, I'm not sure I could give you a particular
Okay, let's
number.
switch gears. Provider legitimacy. This notion of a provider being illegitimate, losing a license, being a hustler, and so forth, being thrown out of a system, and yet that doesn't sync up with other systems. There was a ProPublica piece not long ago. I'm sure you're familiar with it. Could you speak to that?
Sure, and I think that's a great example of data exchange outside of the Medi program. So, for example, as a result of the ACA, Medicaid programs are now required to share their termination data with CMS, and we are then able to take relevant action in Medicare if that provider is indeed enrolled in Medicare, as well as take reciprocal action in other state Medicaid programs. I think there are very good examples. We've had compliance in sharing that kind of data increase dramatically since the beginning of the program. We get a lot more information from the states in terminations that they're able to perform. Now, I would point out licensure decisions are very different from enrollment in Medicare or Medicaid. Those are conducted by non-CMS affiliated bodies. Those are state licensure boards. They operate very independently of us. We certainly can take an action if a license is revoked, but we, as such, have no more authority in that process than anybody outside the licensure board.
Okay, we'd love to help you. I yield back.
Thank you.
Thank you. Mr.